Welcome, everyone. And I'm Linda Niksic, a patient partner and your moderator for today's webinar, a part of 2025 collaborative series of webinars between For Patients by Patients, or PXP, and the Patient Engagement Research Ambassadors at the Canadian Institutes of Health Research, Institute of Musculoskeletal Health and Arthritis. This is the fourth webinar to take place since these started in 2024. Some of you may have attended the PXP conference in September 2024. We're continuing the momentum between this and the next PXP September 2025 with this webinar series. Today's webinar, Patient Partner Perspectives on Barriers and Facilitators to Patient Engagement in Research, is for and by patients and is open to anyone who is interested to listen and learn. The topic was designed by patient partners in research based on their own experiences. Besides the term patient partners, you may have heard terms like patient consumer, patient engagement, or patient and public involvement. The terms used may vary depending on where you live or your own personal preferences. Regardless of the term used, know that we're all here to talk about the same thing: how people with different types of lived and living experiences are working in partnership with researchers. I would like to begin by acknowledging that the land on which I live and work on is the traditional unceded territory of the Algonquin Anishinaabe people. The Algonquin peoples have lived on the land since time immemorial. I'm grateful to have the opportunity to be present in this territory. And I invite you, from where you are, to share your own land acknowledgement in the chat if you wish. Also, Dawn will be sharing a link in the chat for more information on land acknowledgements. A few other notes to make. The webinar is being recorded and will be available on the PXP website after today. Closed captioning is available. You can turn this on by selecting the CC button at the bottom of your screen. You can also select the language of your choice by clicking on the arrow next to the CC. Anything shared in the chat will be anonymously summarized and shared with the recording posted on the PXP website. Feel free to use the chat if you would like to share resources, comments, or a bit about yourself. Because the chat often moves quickly, it won't be monitored for questions. If you have questions, please use the Q&A button. If this is not possible, we can take a few verbal questions. Please click on the raise hand button, then we can unmute you. You do not have to turn your camera on. However, if you ask a question this way, then your voice and name will become part of the recording. And we will take your questions at the end of the presentations. Also, if you're interested in social media messaging, the hashtag for us today, this evening, is #PXP 2025. And the webinar supporter is the Canadian Institutes of Health Research, Institute of Musculoskeletal Health and Arthritis. Let's begin. A warm welcome to our incredible panel of patient partners, Francine, Alex, and Jim. Please see their amazing biographies in the chat. To start us off, Alex, could you tell us about the role of access and support needs of patient partners?
Yeah, I would say so. I identify as disabled, chronically ill, and neurodivergent. And I think obviously many, if not most, patient partners are going to be coming with some kind of chronic illness, some kind of lived experience of chronic or complex patienthood. And as such, they're going to be coming with access or support needs as well. And so thinking about how to accommodate those within the research process, within the engagement process and the partnership process is really, really essential. Um, and so having conversations about that, being open to accommodating is really important. And at the same time, it can be really challenging because I know that for myself, figuring out what my own access needs are and how best to accommodate them is an ongoing learning process. I've been chronically ill since I was about 4 years old. I've been neurodivergent my entire life, and I'm still working out what are the best ways to support myself, and thus what I need to ask of people to support me as well. And I think some of the really there's I don't want to say they're obvious because they're obvious to me because I've worked in the space for a long time. But things like barrier-free access, wheelchair accessibility, captioning, um, those are the more obvious ones. But then also things like what I call temporal accessibility, which is like how are we working on timelines? How are we supporting people who maybe have unpredictable energy levels and cognitive capabilities? How are we providing cognitive support to people who are dealing with brain fog or other cognitive access needs where they may have really important knowledge and ideas, but try to articulate that in writing, for example, or trying to articulate it verbally might be a challenge. So how can we support them to do that? One um, really amazing access support that I've seen in a couple of papers that I've worked on is folks who have trouble translating their thoughts into written text. And so co-authors on papers, they'll have a call with one of the other co-authors and they'll get their thoughts out that way. And then one of the other co-authors will help them translate that into written form, which is so amazing. And I'm someone I fluctuate in that. Normally, I actually find I express myself better in text, but sometimes when I'm going through like a really bad pain or autoimmune flare and the associated brain fog, it's like I just get a complete brain block. And I'm like, I there's a vague shape of an idea in there, and it just will not come out onto the page. So having that ability to talk it out with someone is really important. And having that recognized not just as you're not just being interviewed, you are actually contributing to the authorship of a paper. Because I think that's the other one of the other challenges is that often sort of when you need particularly cognitive access supports, sometimes you can feel like you're ending up in a position where you lose or you lose agency or you're perceived as contributing less, even though that's really not the case.
Wow, that's really heartfelt in the way that you just walked us through, your personal journey and and what it takes also in terms of supports, and it's not obvious, and yet how educational that is for all of us, right? To know that what we're living individually is so unique, and it's very empowering, right, for all of us to just hear what it takes to empower yourself, how you've shared with us. Thank you so much, Alex. And now I'll turn to Jim. If you could share with us your experiences to have a sit down with a researcher or a research team before starting to work with them.
Thank you, Linda. I think sitting down with the researcher just at the start will help everyone. I think of it always as like an interview. Um, That way, the researcher is getting a sense of who that person is and what their skill set is, and how uh, the joining of the research project with the individual and their individual skills can be can become can come together. certainly some people, many I suggest, don't know that much about research, and going and having this conversation will help the patient partner better understand the process and the timelines, because certainly by the time a project is submitted for funding, um, there's sometimes quite a lengthy uh, time frame in between the application and the successful, shall I say, uh, funding application, and so it's important to really highlight the expectations of the research and for the project, but also to help introduce research to the patient partner. But I think it really is important to note here that patient engagement for people like myself living with dementia can be a struggle because many in society automatically label you as incompetent and incapable. So that becomes such an easy uh, out, if you will, to exclude people living with dementia and simply put a tick in the box and say, sure, I have somebody, a patient partner involved, but they can be quickly hustled to the sidelines, especially if you felt the same way as a PhD student felt when she declared in an article by Shoemaker 2021, and this is a quote, "I can't listen to patients. When they start to talk, my ears just stop working. The only thing I can think of is N equals one," end quote. That person classified lived experience, input, and insight as the lowest form of evidence. So a one-on-one conversation will go a long way to dispel any thoughts of incompetency and incapacity.
Thank you so much, Jim. Uh, it's really moving what you've just shared with us. And it builds even on what Alex had mentioned, which already, right, shook us to the core. And then here you are letting us know just how there's still attitudinal barriers and the how shared experiences, lived experience can be still dismissed within the medical field. And I thank you so much for sharing that with us. Thank you. And now, Francine, if I can invite you to share with us as a parent of a child with complex needs. Could you walk us through your experience trying to build awareness of your child's needs?
Thanks, Linda. I'm going to share a little bit, just hearing from what Jim and Alex were saying, just about who I am so that people understand the context. So I am a parent of a child with medical complexity. So I put my hat on as a parent partner. I also am a patient myself living with a chronic illness. So I put my hat on as a patient partner. I am one of the sandwich generation where I'm a caregiver to my in-laws as well. So I put on my caregiver hat as well. But in addition to all of that, as I hear this quote from Jim, it distresses me slightly because I see myself as a researcher as well. So I'm a researcher in shared decision making as well. And to think of the level of evidence and how we compare what's the quality of evidence, it just shakes me to the core because I know how important the lived experience is in shaping not only how we create research, but also what is meaningful in terms of the questions that we're asking. So to hear that my voice as a patient partner, when I put that hat on, my grade as a researcher, passions me to continue this sort of work that we're doing now and sharing those stories. But to go to your question about what it's like to share my child's lived experience. It's really based on sharing who I am as a caregiver, and sharing it through stories. I'd love to, go back and hear from Alex and Jim as well about, how they vision themselves, how they share their story and who they are. I think that's a really interesting way to start off conversations when we sit down with them. But I sit down with researchers, and first of all, I share, I hope you're okay with me being on this panel with you because I might have to step away and do a feeding. I might have to step away and section my child. But I fear sometimes sharing those stories with them because then I think, oh, I'm too much of a burden. Like Jim said, you may not want to engage me, instead just tick off a box with me. So there's a balance there in terms of how you share what accessibility needs you need as a parent of a child with medical complexity, as someone who might have a pain flare up at any time, who might need to step away, with also wanting to be the person that is there to help advise and share my story, my child's story. And I put this out to not only patient partners, where if you're struggling with how to express yourself and who you are and what accommodations you need, don't worry, we all struggle with that, so don't feel so bad about it. But also, if you're a researcher out there and you're listening, think about the fear in your partner's head when they try and share an accommodation. If that means they're going to be dropped off the project, if that means that they're just not going to be interacted with as much, if that means that it's just going to be hard, they're going to be seen as harder to engage with. And these are just those barriers that pop up that we don't even know are popping up. The patient partners see them, fear them. So when we share our stories, we're being vulnerable. And I think it's really important that people understand the vulnerability we put ourselves in when we share our stories.
Well, thank you so much, Francine. And that the way you've put forward to the vulnerability in sharing, and yet there's so much strength in our vulnerability. And when I hear the passion that's coming from you and Jim and Alex, it gives so much hope to breaking down these attitudinal barriers. The other piece that you mentioned about burden, that is very hard to hear, that sharing our vulnerability could be a burden. And it reminds me of like Viktor Frankl's book on Man's Search for Meaning. And he speaks about burden and how it's unique to each one of us and how we have a responsibility in how we carry that. And I just want to thank all of you, Francine, Jim, and Alex, for sharing with us how you're able to communicate what you need, because that's support, and that's something that we all need. And it's so important to know how to communicate that as patient partners. And thank you for sharing personally how you're able to do that. And now I will ask Alex if you could explain the concept of epistemic injustice, or in other words, power differences, and how this can affect being part of a research team. Oh, you're just on mute, Alex.
Sorry, I was explaining, I did not share my intro slide earlier, so I was throwing it up there. And then I started explaining epistemic injustice. So epistemic injustice is, epistemology is sort of the study of the field of knowledge, of how we create knowledge as a society, and really who creates knowledge. So epistemic injustice is the idea that within our society, only certain people are viewed as having the capacity to create or hold or communicate valid knowledge. And that is done along lines of power. People, communities, people who belong to marginalized communities, marginalized identities, their knowledge about themselves, about their own experiences, is viewed as less valid. The ways that they experience and interpret the world are viewed as less valid. And, I think the quote that Jim shared is such an incredible example of that. That is epistemic injustice in a nutshell. Like we in evidence-based medicine, we take what we call the hierarchy of evidence for granted, that the sort of objective knowledge, the outside observer looking at a population of anonymous patients, is constructed as inherently more valid and more valuable and more real than the knowledge that one patient can share about their own experiences, about their own community. And I think we know as patient partners that that is not true, and yet it is accepted. It is widely accepted as true. It's codified as true. Like we have the that pyramid diagram, the stepped diagram. And there are a couple of different types of epistemic injustice as well. There's what's called testimonial injustice, which is that idea where when someone is sharing their own story, their own experience, their knowledge about their community that comes from living within a community that is doubted, it's a question, well, where's the data backing up that's accurate? Or that, the plural of anecdote is not data, which is funny because that's actually that's actually a misquote. The original quote was actually the plural of anecdote is data. So it's a complete misinterpretation of the original intention of that quote. Anyway, but that's testimonial injustice, where we doubt the knowledge that a particular person from a particular group has. But then there's also what's called hermeneutical injustice, which is where people aren't given access to the language, to the conceptual frameworks, basically the ideas and the structures to give voice to their own experience adequately. And I mean, that's something that resonates with me really deeply as someone who, I've been chronically ill since I was about 4. I wasn't diagnosed until I was 30 years old. And for most of my life, I was told that what I was feeling was normal. It's just, first it was just growing pains. Then it was just, oh, you need to exercise more. You need better posture. Then it was, oh, you're just thinking too much about your health. You're neurotic. You need talk therapy. And it's still that, to be honest. Now that I'm dealing with some new autoimmune stuff, I'm getting recommended a lot of cognitive behavioral therapy again suddenly, despite the fact I've got literal autoimmune inflammation in my eyeballs that they can see on a microscope. Somehow that's something that I can fix with talk therapy, apparently. Anyway. Point being that when you are gaslit that deeply for that long about your experiences, when everyone around you is telling you that your experience is invalid, you start to believe it. And that in and of itself, you lose access to being able to describe your experience, to being able to describe the injustice that you're experiencing. And I think that's a really crucial piece to keep in mind for patient partnership, for any kind of research, any kind of trauma-informed research, any research with marginalized people, marginalized communities, is that we may end up with people sort of over-reporting benefits and under-reporting harms, not just because there's a lack of safety to report, but also because they have been taught that they're not experiencing harm, and you learn to squash it down and to think, oh, it's my fault. Oh, these interventions I'm being given are fine. They're great. I'm just not trying hard enough. And I see that I'm so skeptical of so many interventions that I see that report positive benefits, because I wonder how many of these patients are who I was in my 20s when I was saying, yeah, these lifestyle interventions are working for me. I'm changing my diet, and I just need to stick with it this time, and it's going to help. And turned out, no, I just needed daily antihistamines and mast cell stabilizers. And then suddenly I was able to exercise and eat healthy. But yeah, just sticking with it never really worked. But I was convinced for so long that it was, that when doctors would ask me, I would over-report that. And sorry, I'm rambling now, but even still, I do that as a survival strategy in clinical encounters, where I over-report how much mediocre lifestyle interventions are helping me, because I also know that if I'm honest about how little they're helping me, I'm going to be perceived as having fixed illness belief and as being a difficult patient. So there's so many dynamics that go into sort of how patients report their own experiences. And I think that it's important to keep in mind that it's not just a matter of working with patients. It's about how do we build structures in which they feel safe and have the space to work through those experiences of gaslighting that a lot of us have had.
Thank you so much. the forthrightness, the determination that you have to share with us at this level, because it's so impactful the way you speak about the survival strategies that you've had to use. Like, just the way you're framing it is phenomenal. It's like you're educating us on how we can actually call this out, right? When we're not feeling safe to call it how it is, our experiences. And even the way you've walked us through testimonial injustice and breaking it down so that we can be equipped. So when we are encountering this, that we can express ourselves and use language and concepts, and how beautiful it would be to have articles that cover this and equip patient partners. I would love to gather all that you all have said so far. And maybe we're not even midway through tonight, but it's already it's just so touching. Thank you so much. It's so heartfelt how you all are sharing from your hearts. I thank you so much. And also I was wondering too, if Francine, if you could give your perspective as well around power differences that can possibly like affect being part of a research team.
For the unmute button. Yeah, of course. So I think that when we think about power, we often don't think about exerting our power as like an explicit thing. But what we don't realize is how power and differences show up by just doing things that we've been traditionally taught to do or just are expected to do. And what often happens when we're engaging with patients and families is, as researchers, we're going through the entire process that we've been taught to do, right? We come up with a research question, we put it together, we get grant funding, and we kind of figure out, what stage are we at in the process. And then we bring patient partners in, and we don't necessarily know how exactly, my intention is really to listen to them, but maybe I brought them in really too late in the process. So now the power is like, well, I decided and designed what we're doing. I'm going to ask you for your feedback, but I don't really have anything to change. So explicitly, you're not trying to exert power, but we haven't necessarily thought through how we're going to do things so that we eliminate some of those power differences. So I don't know. Oh, I've shared the wrong screen. That's what I did, didn't I? Sorry. And now I have to stop share. Sorry.
No worries.
A slide that I'm just going to share. If I could share the right screen and not mess it up. Let's see if this works. No, you're not going to let me do that, are you? No. So I have a slide that I share that is like this really complicated mathematical equation, and there's a bunch of people standing in front of it, and at the bottom it says, so what do you think? And we often do that to our patient partners, where we come up with this complex thing. We've thought it through. We spent hours in front of our computers. We've read all the literature. And then we're like, but you have lived experience, so what do you think? And we don't support them to be like, well, this is what I think your lived experience could contribute to, or giving them a safe space right at the beginning to just share their stories. And then as the researchers take our expertise of what the research process is and say, okay, let's work together on how we can guide this into the right research question. This is how I can help you think about connecting the process that we work in and the experiences that you have and combine them so they become meaningful to both of us. It's achievable, it's meaningful. And we don't think about that. And then at the end, where the patient partner is disengaged, walks away and goes, yeah, they talked to me down to me because of this, and they were using language I didn't understand, and they used too many acronyms. And it wasn't that was an intent to exert power, but thinking about how we reduce the barriers that are not understanding the research process, not having the opportunity to share your lived experience and connect it to the research process, not having the opportunity to even be told what is the value of my story and where does it connect to the work that you're working on. I'm not getting paid to be a researcher. I'm just telling you my story. I don't know where it connects in. I don't know where it finds funding. That's what we need to think about when we want to reduce the barriers to engagement and we want to reduce power differentials. And the first step to doing that, if I want to give a concrete way of doing it, is being authentic in terms of what you know and what you don't know. Like, just, it goes such a long way to say, I know the research process, but I have no idea what it's like to live outside the hospital with a kid with medical complexity. I've never cared for a child on a ventilator outside of the hospital. I don't know what that's like. Tell me your story. Tell me your challenges, and then I will help you as a researcher connect that to the research that we're doing. That's how you reduce power imbalances. That's how you become authentic. That's how you start on a level playing ground of together, we're going to figure this out.
Oh, I feel like there's a paper here. There's a paper in each of what you're all saying, and then potentially some incredible book that just keeps evolving. Wow, that's so powerful, right? That equal level playing field, that respect for your story, that at the forefront, patient partner, that you're listening as a researcher, as someone in the medical field, to just understand where the patient partner is living, what they're living with, and listening, really listening deeply to your stories, right? Our stories. Thank you so much for that. And Jim, if I could ask you, as you reflect on what you have learned about patient partnership over the years, what advice do you have for us?
How long do I have, Linda?
You know, we have lots of time. The floor is, we're trying to understand each other. So it's and of course our virtual audience, they get all the time in the world too, as much as we can tonight.
No,
We planned at 7, but it's okay. We'll
I want to start just with a couple of quotes out of a paper, Jack Nunn et al.'s 2021 paper that was entitled Involving Elderly Research Participants in the Co-Design of a Future Multi-Generational Cohort Study. And it was written, involving participants positively impacted the proposed study design by improving the research objectives, developing protocols, influencing funding decisions, and improving ethics applications. I loved that paragraph. But one researcher noted in that paper, what I learned is that sometimes the researcher's assumptions about certain things can be off or even incorrect, and that researchers can miss critical points that are important to participants and the study. And I look at think of those and go over the reaction of some researchers that I've had. I remember being in an advisory group with a project, and it was fascinating how a couple of the researchers, especially, I noted would almost walk away from me because of my dementia, but it really, to me, illustrated the feeling that what does the advisory group have to say that will be of value to me. And I think that research and the research process are new to most people. And so I would, first of all, encourage um, the patient partner to start with patience and the desire to learn and to teach. Hopefully, the researchers will respect that they too are teachers, but they too are learners. Um, I was, I was diagnosed in 2007, and my first research project was in 2011. I had, the background of walking the journey of dementia, of Alzheimer's with my mother, and plus my professional background. I still, I took the time to understand what I was living with, what I was diagnosed before I really got involved in research, um, because it's so important to understand yourself, how you are in fact going to live with dementia, how you are in fact able to adapt, and some of that adaptation effort that you are creating for yourself will sometimes be just that hook, if you will, that a research project, a researcher will just have that, slap on the forehead moment and say, yes, I had not thought of that. And in fact, I was one of, I think, three people, patient partners on a project in pre-COVID. We were on a conference call, and the researchers were on the conference call, but had been told um, that they were not to say anything, that the conversation was between the three of us. And a couple of times I heard very faintly in the background after something was said, but a researcher was heard, I heard the researcher say, oh, I had not thought of that. And another time it was, oh, that is a different perspective. And so I always cite that example because to me it's that it's that intangible of involving patient partners, but it's that valuable intangible that sometimes can be hard to really what's the word um, um, really add substance to convince the researcher why we should have been brought in at the very start of a project.
Thank you so much, Jim. That is, talk about nailing it like brilliantly in terms of what does it take? Why does there even need to be justification? How is this not obvious? And you sharing us an example specifically around where researchers are like, wow, that's fascinating perspective. And it's like, well, we each have our own unique perspectives. It's those diverse perspectives that add strength, right, to the research. And taking the time to understand each individual perspective is just vital. Thank you so much for that. And now I'll turn to Francine. If you could give us your advice for researchers on what they can do to support patient partners on the team.
So I'll build on what Jim is saying and really think about when you engage patient partners to give those opportunities for your own aha moments. So you need to set conversations up so that conversations will flow and you're not just asking them and peppering them with questions on what do you think about this? What do you think about this? We thought through this, but really allowing a safe space where they can feel vulnerable, share their story, and together you build on those stories. that takes time, that takes relationship building. It's not something you can do on a deadline, especially if you're coming up to a grant submission deadline or you're trying to get a paper written. So my biggest advice to researchers is plan for engagement. And to plan for engagement well, you plan for building relationships. Because as much as, I've had those moments in a research study where I've said, is your research question about making your life easier, or is your research question about making the lives of your patients and families easier? And sometimes it clicks and they're like, oh yeah, maybe we need to think about the research question a little bit differently. But the other thing I've also heard, which is, slightly depressing, is that I've always heard some researchers, some clinicians say, oh, but that patient story is wrong. Like, that's not right. And I hear that and I think, what's not right? Because the patient story is the patient story. How we use that story to inform research, or how that patient understands something within our system that you might understand much better than them, might be the problem that we actually need to address. So the wrongness of the story might actually be the research question that we're looking into. So, my advice is not only give safe space to listen and hear the stories, but support families to tell the stories and then guide them into how those stories become solutions, either through research projects, either through publications, or through building foundational systems that make engagement easier. Those are all things that we want to do. We just don't get paid for it. We don't have the power to do it, and we need your help to do it. So that's my advice.
Well, thank you so much, Francine. So much there to unpack here. I feel we could even break that down into so much time to understand even further the responsibility that could be taken, right, on all those fronts, especially around just understanding, as you say, like instead of dismissing, it's hard to imagine, but here it is, right? It is echoed today that it can be a barrier where a patient partner's story or a patient's story is dismissed or ignored or judged, right, for not fitting within the realm of, the solutions. And then to your point around how we can address, if there is such a disconnect between research and lived experience, that in itself for us to explore even further. So thank you so much for bringing that forward. And also wanted to get into when it comes to how patient partners can impact the team. In my experience, and I live with muscular dystrophy, so I do in terms of work that I do on research teams, but also so what I find is that accepting every person for where they're at is really important. And I suppose it kind of echoes what each of you have shared tonight, right? About the uniqueness of each of our lived experiences, and also from the researcher's perspective, right? Because they also have their experiences too to share. And could you also, all of you, share your point of view of how patient partners can impact the team? And Jim, would you be able to go first with sharing with that? Thank you.
I think the impact comes from stories. The impact comes from shall I say, teaching and not demanding. I read a little report saying that said a 14-year-old boy from Tennessee proposed a challenge for lawmakers to spend a day in my wheels. So 10 members of the Tennessee House of Representatives agreed to use wheelchairs for a day at the office. And one member was quoted saying, "I expected it to be difficult. but I had no idea how frustrating it could be to just simply get around. He admitted that it's really been an eye-opening experience. And that, Linda, is how you impact the team and the research generally. The boy, if he had been on a research project, wasn't demanding. The boy was just, sure, take it for a day. Then let's let's talk. And I think that you're not going to be able to do that with every researcher because every researcher is different, just like all of us are different. But and so your approach to that individual will, or those individuals, will often change, from one project to another. But as I read in another paper, patient partnership in research represents an opportunity to leverage the knowledge, skills, and experience of not only researchers and clinicians, but also those that research directly impacts, patients and families, to collaborate towards creating impactful and meaningful change in how research is conducted. And it's so important to I guess try to illustrate to researchers your openness, your willingness, as I said before, willingness to listen, and hopefully willingness to advocate. But I just to personalize this discussion, I when I leave the house, oh, it doesn't show up very well, but every time I leave the house and go to a meeting, especially, I put on a lanyard that says, "Please be patient. I have Alzheimer's disease." And that, in my mind anyway, um, is being upfront with what I am dealing with, the diagnosis that I have. But I like to think that it shows that I am open to any questions from any member of the research team. And and so that here I am, but this research is relevant to or will impact people living with Alzheimer's, people living with dementia. And that's how I advocate to educate. And hopefully over the years and all the researchers that I have been working with, I hope that I have been able to educate them even a little bit.
How to advocate to educate. Brilliant. And also too, Jim, when we started, you shared as well how you have loved ones, right? Who also you have observed and lived with how they struggled with Alzheimer's. And then for you to be so forthcoming and being able to share so openly with researchers and everyone and with all of us today, that's really like immeasurable how invaluable all the sharings of today are.
Yeah.
I thank you
Thank
all.
you.
I think I'm just I'm so touched and moved by each of you. Thank you so much. And I was going to ask as well, Alex and Francine, if you could let us know how you feel out a team as you start to work with them and what you may decide to share and not to share. And maybe Alex, if you're okay to begin. Yeah. Thank you.
Yeah, I would say so. I think I tend to be a lot less proactive than a lot of other patient partners about seeking out specific teams of researchers to work with. I often describe myself as like a feral cat or a shadow cat. I wait for them to come to me. And I'm realizing sort of as I'm sitting here hearing everyone talk that in itself is somewhat of a trauma response, not necessarily from past experiences with as a patient or as a patient partner, but within academia, which is a whole other can of worms. But I think there is a benefit to it in that I tend to be very open and frank about my ideas, about my criticisms of the healthcare system, of clinical medicine as a system of knowledge, as a system of practice on social media. And so the researchers who tend to come to me are kind of already prepared for how I operate, how I express myself, which tends to be frank. And sort of going back to the question of like how we impact the research teams we work with, like that is something I struggle with because my advocacy comes from a place of profound anger. I am so unbelievably angry about the ways that I have failed to access care for my entire life, that I am still, as someone who has multiple diagnoses, who is an incredibly experienced patient, and I like to think pretty good at advocating for myself clinically, I still cannot access the care that I need. And so I am profoundly angry whenever I go into advocacy spaces. And it's like that meme from the Avengers. It's like, what's your secret? When Captain America asks Bruce Banner, what's your secret? And he says, my secret's I'm always angry. And that's literally it. I put on a friendly face because the anger is always, always there. But also at the same time, sometimes it seeps out, whether that is because I'm going through a particularly difficult time trying to access care as a patient and it's just overwhelming me, or because I'm sitting in a meeting and I'm seeing everyone share these high-minded ideas of how much we're helping patients with our individualized self-management programs, that you need to frankly be middle class. You need to have a family supporting you. You need to have a diagnosis and baseline medical treatment for those self-management programs to work for you. And we're all sitting in a room talking about how impactful these self-management programs are. And it makes me furious. And so sometimes it just spills out. And I struggle with how blunt I can be because so much of the insights that I'm sharing are grounded in trauma. They are heavy things to be sharing. And I worry about the weight of what I'm putting on the researchers I work with. And particularly because the researchers that I work with are people who care deeply. They are the ones who are really invested in trying to change the system, change how we do health research. And they're the ones who take all of this very much to heart. And so at the same time, I feel somewhat protective of them. So I feel like I am always caught in this back and forth of I'm trying to repress my feelings somewhat, both just as a communication strategy to be better heard by the researchers who are not as invested, and also so as not to overwhelm and burn out the researchers who are invested, and then feel angry at myself and at the system for the fact that I am suppressing what I'm feeling on behalf of other people. So it's this real back and forth, but I would say in terms of feeling, weirdly, it has been successful for me as a strategy in finding collaborators who I've been really grateful to work with and who I think I've had really meaningful collaborations with, because the fact that I'm so open about the fact that I believe that clinical medicine is fundamentally violent as a system, that it needs philosophical level changes, that we can't just bandage it over by creating new surface level interventions that target individual behaviors. The folks who are receptive to that, who stick with me, when I'm able to be open to that, and when they don't back away from that, that usually signals it's going to be a really successful partnership. And there have been a couple of times where I love that Francine and Jim have been talking about the research questions, because it really comes back to that. I've had a couple occasions where I was sort of brought in on a paper, on a grant, and I came and I said, like, the name you've given this project is excluding a whole group of people, or the research question you've asked is objectifying patients and treating them as passive objects to work on. And I was convinced that that was going to be like, I didn't think they were going to necessarily kick me off the team, but I thought our conversations were going to be very superficial from then on. That was pretty much what I was expecting. And I was really pleasantly surprised when, the response came back and the one team was like, yeah, you're right. We need to change the name of this project. And the other sort of restructured, it was too late in the project to sort of really change the framework we're working with, but we thought about how to restructure our interpretation and our discussion of that framework in a way that was less objectifying. And both of those, and I think that's really key too, is recognizing like you're not always going to be able to get the perfect solution. It's often going to be a matter of compromise, but that openness to saying like, you can say this is fundamentally wrong. And then the response isn't just to shut down, but to say, okay, so like, how can we find a good enough solution for now? And then we do better for next time, I think is really, really crucial. And I think too, sorry, again, I'm rambling, but I
Take
think
your time, Alex.
okay,
Please take your time. No worries, okay?
I think another thing that I sort of see a lot from researchers who care a lot is sort of saying, we don't want to engage this marginalized patient population and do it the wrong way. And I also think I sometimes feel like that becomes a little bit of a crutch because I see it happen so often. And it's like, at what point do we put the effort in to engage them the right way? And so I think too, a key part of that compromise, for a compromise to be effective and not just reiterating injustice, reinforcing injustice in and of itself, I think the key part there is, okay, and how do we plan for that future step to do this right the next time? Like it's okay that we can't do it right this time. We'll do the best we can this time, but you can't just bracket doing it right indefinitely. It's like you have to build the framework for, and I think what Francine said, it really is, it's about how do we plan to do this right way, and how do we do that relationship building infrastructure alongside the work we're doing right now is really key.
Thank you so much, Alex. And there's a couple of things here around just the way the raw anger, and for there to be researchers and research teams who could just get it, right? That how to listen to where the state of being is, because that frustration, your life looking and searching and trying to find, and there's so many of us, right, in a predicament, in a situation where medically nothing can be done. So it's really up to us as individually to figure it out. And then how do we build that connectedness with researchers, with the research community? And the other piece, when you mentioned about research and frameworks, and you gave a specific example, and I'm wondering, yes, they did make some changes, you said, but it kind of was already in development, so it wasn't like from the conceptual state. And I wonder, is there still possibility for you to have an impact on future research with that particular example? That's my hope. And then there's also just the way you're putting forward the solutions. It's so much work still in that space, right? To try to figure out how to engage, to do it right, but then how do you even measure that progress is happening in that space, right? How do we measure that? How do we begin to measure it even? Yeah, thank you so much. And then I'm going to turn to Francine, and I'd like to know, for all of us, if you could share about learning from barriers to patient engagement.
Yeah, I think, my journey through patient engagement has been an interesting one. I started as a patient partner when my son was still in the hospital, and then became, a parent partner on my son, and then went through reemergence of my own illness, and then engaged a little bit on that, but I still stay away from engaging too much on my own illness, and more as a caregiver. It feels safer to me in that space. But at the same time that I was learning how to be a patient partner, I was also going through graduate work and doing my own research and emerging as a researcher myself. So where I was early on, I would be very, I want this space. I'm looking through the chat. I would bring the folding chair to the table. I was the one that wanted to, really. And then as I became a researcher myself, I realized that, I am really bad at doing it as a researcher. I can really stay what I want to be as a patient partner. I can advise patient partners on building their confidence in doing what they want. But as a researcher, I struggle to do really good engagement. And it's not because I don't want to. I do. I know what the value is. I struggle with embedding it into that so challenging research process as an early career researcher, and the different time commitments and pressures and what you need to achieve when and what the timing is. So what I take from that is that the barriers for researchers are real. The barriers on embedding patient engagement into a research process is real. We don't all have money to compensate. We don't all have the ability to spend the time to build those relationships. But what I ask of those researchers that are very much aware that these barriers exist is being open and honest with the research partners that you're engaging and saying, look, I might be really bad at this, but let's talk about the bad stuff. You tell me when I've done something bad so we can build on it. That's how we make change from barriers. That's where we say, I want to have an open and honest conversation. And I had this with some of my patient partners as a researcher where I screwed up, didn't I? Like, please talk to me about how I screwed up, because I need to fix it, but also you need to give me your experience of being a patient partner as much as your lived experience in your illness. You need to share your experience of being a patient partner, because if we don't talk about that part, then we don't make patient engagement better as a whole. We don't make patient partnership better as a whole. So I don't want to just sit in myself as a patient partner and say, I have a story to tell, everyone should listen, or this didn't work out right, but I want to be able to talk about the dirtiness of patient engagement. I want to be able to talk about, the research study where, I got really good work done. It was so engaging. I really felt like a partner, but I spent way too much time and I sacrificed my own illness on that. Like, that's something that we need to talk about, because there were pros and cons of that. And maybe it was my own trauma response to push through and get something done and sacrifice my own health. But I need someone to download that too. I need someone to talk to. And maybe it's the PI on the study, maybe it's a research coordinator, maybe it's someone in a patient engagement office or patient experience office that you can have those conversations with. But that needs to be talked about as much as my lived experience as a patient, caregiver, or parent. So we have to listen to a lot of stories. We have to make space for a lot of different stories.
Oh, thank you so much, Francine. And it's so powerful the way you also framed it in, how did you say it, like a dirtiness of engagement processes. And yeah, it is mucky, isn't it? And we're kind of in the mud together. And how do we get to that point where, and it comes across too in Alex, when you mention about the anger, in Jim, when you mention about advocate to educate, it's this sense of, how do we reach you? How do we reach you without exhausting, without expending ourselves, our families, and right, and all the other roles that each of us can have, as well as researchers, right? So it's and I come across to the way you mentioned, Alex, around how invested people are, and maybe some aren't as invested, right? And where's the readiness to move forward in a way that there is some equal level playing field. Thank you so much. And we do have some questions from our virtual audience. Thank you for that. So I'll go through them. So our first question, and I believe it's to each of you. So I'll put it forward. What if the researcher doesn't realize that they need to speak with a patient partner at the beginning of their project. Many researchers don't do this. So if I could ask maybe Alex, if you could begin.
Yeah. Yeah, I don't know that I have a great answer other than that sort of when I'm brought in later in a project, I try and provide my feedback on the research question as well, even if it's already, I don't know that I'm doing that so deliberately. It's more that I tend to be quite blunt. And it frustrates me when a bad question is being asked as both a patient and a researcher. So I just sort of I share my thoughts on that. And again, it's an effective strategy for me, and that the researchers who aren't as inclined to engage deeply with that, they're maybe not going to engage with me again, but the ones who are then maybe going to think of me when it's time to define the next research question. They're going to maybe bring me in a little bit earlier, recognize that that's a thing they need to do, and then also if it's an appropriate project, maybe bring me in to do that. And I think I think it does tend to be reasonably effective for me more often than not, because I think often, as Jim has talked about, you share things that surprise the researchers, and when they realize that there's so much that they weren't considering, that there's so many assumptions embedded in the ways that they've asked questions. I think, there a lot of the researchers that we're working with, they want to be doing good research. So when their sort of attention is called to the fact that they've embedded tons of assumptions in the question, in the framing that they've used for their project, they realize that, okay, next time we have an opportunity to do better. So there's a little bit of optimism in there, I think, in that it's really just about revealing what they're missing by not having those perspectives, that there's a real value in bringing them earlier.
Thank you, Alex. And
Maybe I'll jump in a little bit too.
sure, yes, please.
When I read that question, my first thought that came into my head was forgive them, for they did not know. and take that as a learning opportunity, right? They've already reached out to you. It may not have been at the beginning of the project, but at some point they did reach out to you, maybe because they were nudged by someone else to do it. Maybe it was feedback from the reviewers that you need a patient partner on this study, and now they're looking out for the right patient partners to work with on that. But most importantly, take it as a first step. Because if they've engaged you at some stage in this study, like Alex said, there is a higher potential, higher odds that they will engage you when designing the next study, when creating the next research question. So I take every engagement opportunity as a learning opportunity, as a relationship building opportunity. And I don't judge necessarily when, I just judge on if they've actually listened while engaging.
Thank you, Francine. And Jim, is there anything you'd like to add?
I just try to adapt at that moment in time. And hopefully the during the course of the project, uh, I'm thinking that with good input and assistance throughout the project, that the researchers will learn from that. But I was just thinking as Francine was talking that I was co-PI on a project that um, the two what I call real researchers um, uh, put in the initial application for funding and it got rejected. And then the three of us talked, and that's really about all we did for the second submission, and it was rejected. So then they said, come on board. And so we did redo the project and the vision was different and so on. And when they did that, it did get approved. So in my mind, they had lots of takeaways, number one, for their own work. But I always believe in what is it, 6 degrees of separation or something, that they won't just keep it to themselves, that they will tell other researchers what their experience was. And with that, then I hope that spreads beyond, in my case, dementia, and go into other research areas.
Thank you so much, Jim. And now I'll move on to our next question. It starts with, so important and agree about power differentials. I wonder, how might we shift this paradigm? Example, even new language like lived expertise versus lived experience. And more importantly, how do we as a patient partner community, in brackets with researchers, and bracket, give voice and opportunity to those who are less likely to be involved. And in brackets in particular, I wonder about low income, low formal education, question mark. Does anyone have good examples of how to raise issues that is also stigmatized? For example, patients in poverty, and find ways to level this economic power dynamics as well. Is there anyone who would like to be?
I'll take this one with a little bit of a call to action for people on here, but also a little bit of, context about the challenges that come with engagement, but also the time that it takes to do that. So I think researchers, and I say this broadly, but I think the system of health research as a whole needs a lot more support in terms of making engagement easier, especially for stigmatized, marginalized populations, right? It's really challenging if you haven't built relationships with some populations already or have leads in through leadership within populations to get in there and have an authentic, meaningful Q&A with them, or understand their lived experience, or listen to their stories, or even have a chance to hear their stories. And because of that, I think more investment as a system and more investment as, people involved in research of allowing these systems to exist to make engagement easier, allowing places where voices can be heard, allowing places where patient partners and community members feel like there's a point in sharing their lived experience and stories in a safe space, need more investment. And I think that, we're at a collective point in patient partnership and as a whole, where we're having a lot of these seminars. The next question I read talks about all the frameworks and all the work and all the research that talks about it. But we need to start advocating, not for individual partnerships or individual participants on research study, but really start advocating as consumers of health research, as taxpayers that fund health research, as people that benefit from health research, to really start advocating for, make my voice easier to be heard. Invest in the work, the money that it takes to build relationships with marginalized populations. Many of you might struggle to even believe that, translating surveys is not funded unless you explicitly ask for your surveys to be translated. Yet we often say, we should engage those that speak a second language. We need to expand how much research is done in those languages. But then we don't actually spend money on translators to translate surveys. That's what we need to start asking for if we truly want others out there to have their stories heard. we need to come together as a community and start asking for the collective voice of patients and families to be supported so that we can better engage as patients and families within these systems, especially around stigmatized, marginalized populations.
Can I jump into a thought?
Yes, please.
Yeah, I actually just want to flag there was some great conversation happening in the chat that I caught a glimpse of earlier. I think Michelle and Susan were talking. I think it's particularly relevant considering how much we've been talking about how important it is to bring patient partners early in the process to define the research question, because a big issue here is that that's before the project is funded. And so you don't have funding yet necessarily to pay the patient partner to help in developing the research question. And that is a real problem because structurally you are then ensuring that you only are getting the patient partners who are helping you define your research questions, your entire framework, which as we've just finished saying is so crucially important. Those are the patients who can afford to donate of their time, who, they're not the patients who are living in poverty, who are working subsistence jobs, who are, supporting their family or lacking their family's support of them. So I think that's a crucial issue. And that's really, it's more of a policy level issue to solve it meaningfully. But I will also say, one of the researchers that I'm working with is incredibly willing to work this to figure out where we can find little pots of funding. Like she is very dedicated to, and I think this is maybe more applicable to, she's an early career researcher, but sort of the researchers who are a little bit more stable in their career, because she's able to give of her own time to figure out how can we cobble together tiny little pots of funding to put some funding together for you to be involved in this project from the earliest stages. And then I would say another sort of compromise strategy that I've seen from other sort of less stable, less secure early career researchers is how can we create the impetus for funding through means that don't demand too much of patient partners. So one of the groups that I talked about earlier, I'm working on an environmental scan of with them, looking at gray literature and social media. And I mean, it's not ideal in that there's power issues there, and that we're fundamentally on a career and a publication impact factor level benefiting from anonymous people talking about their traumatic experiences on Reddit. And at the same time, thinking about, again, how you get from the compromise to the ideal, to the good. We are doing this with the goal that this is a way of securing funding for a larger project where we can do meaningful and fairly paid engagement with people around experiences that have not been adequately captured in the literature so far. So there are different, depending on sort of where you're at as a researcher in your career, there are different strategies you can take to support patients to engage them fairly, while also recognizing like we need policy changes as well to really make this happen properly.
And if I can just add one more thing to this as well, we need policy changes. We also need methodological changes as well. So we fund clearly a qualitative research study where we will interview focus groups of marginalized populations that exist homeless on the streets. And there will be no problem to sit down but the questions are already contained. The focus groups are analyzed. There's no back and forth in terms of, it's not engagement, it's qualitative structured research. Fundable. We can give them compensation for reaching out to them. We can buy them food to say thank you for participating in our focus group. If we wanted to do the exact same thing, but make it a much more back and forth conversation where the end goal is to create a research study or a meaningful question or research question, not funded, not something that is put into a grant that you can get paid for and supported. So I think that, we need to think about how we elevate the methods around engagement as well. And this is, something within patient partners asking for as research questions or, as things to publish on that we can co-publish on is how did I feel when you engaged with me rather than interviewed? What was the outcome of those back and forth collaborations? I think we need to start considering where in the literature we can start building those in. and then find those publications that'll accept them so that to answer one of the questions about, what is it to change language and power? This is one thing to change language and power is flood the publication market with things around the methods of engagement and how they are valued and distinct from qualitative experience studies of what it's like to live on the streets or something like that, right? Like we want to engage on that and build on it. We don't want to just study.
Thank you, Francine. Thank you so much. And Jim, I just wanted to make sure, is there anything you'd like to add?
I just I think there will always there will always be a level of power differentiation. And certainly for the first 1, 2, maybe 3 times that a patient partner is actually there with researchers, there will be, because for many of the patient partners, this is a whole new experience for them. And oftentimes the meeting will be at the university, so that in itself emphasizes the power differential. I've said in some presentations that, the first meeting that you have, again, one-on-one, hopefully at the start, have it at a coffee shop. Have it not at the individual's home, not at the university, but have it somewhere where everybody's either comfortable or uncomfortable, one or the other. But make it impartial, so that you reduce that beginning of emphasizing the power differential. And but once a patient partner has been involved a few times, they will have that confidence and realize that the value that they bring to a project, realize they are able to say, you know what, I question what you just said. Um, and provide that input without feeling, oh, like, should I? Oh, I really want to say something, but I don't feel I can or should. But they'll soon find their feet and move forward. But I think to say that I think it's wrong to assume that we will, either every project there's a power differential, or we will never change that power differential, because we really are able to change that power differential. Just takes a little experience and, saying what you feel is appropriate at the time.
Thank you so much, Jim. And we are to finish right at 7, and we have 5 minutes. I do want to thank everyone who's put forward a question. I want to really appreciate it. They also, if I think we maybe have time for one more, and also want to just highlight and flag that the other questions we'll have an opportunity to respond to them once the recording is available. It'll be the responses will be featured in the chat of that recording. So just wanted to make sure that everyone who's put forward their question, it will be addressed. Thank you. And so our final question for this evening that we'll be able to take in the time period I think that we still have. It starts with, I've often thought about how we build community in a way that addresses the psychosocial nature of partnering. What's needed in this area to make it accessible?
I'll start off without really answering the questioning, but just saying how needed community is in patient engagement, patient partnership. I think PXP is really leading the way in terms of bringing people together as community of patients, for patients, by patients. we really need to start supporting each other in terms of, what is good engagement? When does it feel icky? Is it okay for it to feel icky? And when it does, what do I do about it? We're not necessarily going to get that from the researchers that we're partnering with or the institutions that we're in. I think more and more institutions are trying to build that in. I'm really focused on making that work happen at my institution. That's really my goal. But building community, I think, is so important if we're really going to push this forward. Otherwise, what's going to happen is we're all going to stay in our little silos and we're all going to engage on how we want to engage, and it's going to be fine. But I think we're going to do this together. The best conversations I've ever had are with other patient partners where you just go, oh my goodness, I wasn't alone. Like you just validated my feeling, and it's okay for me to walk away from this research, or I need to invest more time in myself right now. We need community to achieve that. So that I'm just putting the plug to say, if we can make community happen, we can lower the barriers. Institutions don't like patients talking to patients. They think we're going to share misinformation or we're going to just complain about them behind their back. We need to show that we are here to support each other. We need to support each other. It's valuable to support each other.
Francine and Jim and Alex, do you have anything to add?
I just put my thought in the chat.
Okay,
We can learn from each other
thank you.
and
Alex?
gain confidence from each other.
Oh, yes. Absolutely. And Alex, just wanted to give, yeah.
I think really just, to echo what Francine and Jim have said, it's we have peer support sort of for patients, but I think peer support for patient partners is also really, really crucial.
Thank you. And looks like we're coming to a close. I do want to thank so much Francine and Alex and Jim. Also, we have Dawn, Hetty, Rabab, and Eunice who've helped us as well and supported us tonight. Thank you. And to our wonderful virtual audience, you're so awesome. And thank you for the incredible questions as well. We ask if you could take a few minutes to complete the survey. The link will be placed in the chat. We would like to ensure we keep providing content that is important to you. Also, you can sign up for PXP mailing list to keep in touch with us about future webinars. And our next one will be before the end of the year about success stories related to patient engagement in research. Don will put the link in the chat for that as well. I'd like to thank you all again and wishing everyone a wonderful evening.